Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral, fully occluding dead skin plugs. And I'm just commencing with this left ear first. Sometimes it's difficult to differentiate between dead skin plugs and earwax plugs, but dead skin tends to be very reflective, and you can see here that the light that we're shining into the ear to illuminate the inside is being reflected off the surface of the dead skin. Earwax is also made up of dead skin. It's made up of around 60% dead skin, and the remaining 40% is a combination of oily fatty secretions and oily sweats, and they all amalgamate together to form earwax, whereas a keratin plug is just dead skin. Also, dead skin generally has more of a lighter complexion than earwax, although dead skin can oxidize and it can become darker in appearance, but its normal colour and shade is that of a more paler, more light orange, almost yellow appearance. Now, another way of differentiating is how well adhered this plug is to the canal wall. With dead skin plugs, the outer layer of the skin that's enveloped itself around the plug of dead skin itself is still semi-attached to the canal wall. So you can also have a feel of whether it's a dead skin plug or earwax plug when you're in the ear itself manipulating it. And currently this plug, although I'm reducing its size, it's not moving. Instead, I'm peeling away the outermost layers. You can think about it like an onion. When you've got a dead skin plug like this, you have the core, and you have these outer sheets, outer layers. We call them squams, and they the structure of these is very similar to an onion, and you're just peeling away the outer layer. And by doing that, you're actually making the core plug smaller, so eventually it'll become a bit easier to remove. Now, as you can see, this patient's got quite thick hair strands, and these hair strands are only located on the outer third of the ear, the cartilaginous portion. As we enter and we go deeper into the ear, you'll see you won't see these hairs, and the reason why these hair strands are on the outer third of the ear canal is because the skin that lines the outer third is different to the skin that lines the inner 2/3. So the outer third, the cartilaginous portion, you have a thick layer of skin. It's got 3 layers. You've got the epidermis layer, which is the outer protective layer of skin. You then have the dermis layer, where you have all the elastin, the collagen. And in addition to that, you've got the hair follicles. You've got the sebaceous glands, which secrete sebum, which is one of the ingredients of earwax. So this is an oily, fatty secretion. It's full of organic compounds like alcohols, cholesterol, squalene, long chains of saturated and unsaturated fatty acids. And then you've got the ceruminous glands, which secrete an oily sweat. And these ceruminous glands are unique to the ear, the inner groin and under the armpits, and they are modified sweat glands. They're actually called apocrine glands. And the sweat secreted by the ceruminous glands is more of an oily sweat, as opposed to the more watery sweat that we find on our scalp or on our brow after exercising. And they're secreted by the eccrine glands. So you have eccrine sweat glands, and you've got the modified sweat glands called the apocrine glands. And then you've got the deepest layer of skin, the subcutaneous layer, which is made up of fatty tissue and connective tissue. So you have 3 layers of skin, and in the total thickness is about 1 millimeter in thickness. So the hair follicles, as I mentioned, are located in the dermis layer. But in the inner 2/3 of the ear canal, there is no dermis layer or subcutaneous layer. We only have the outermost layer of skin, the epidermis, and that sits directly on the bone. So the skin that lines the inner 2/3 is far more delicate. And if you've been watching my videos and following my channel, you know how much I talk about the importance of being so gentle with the inner 2/3. Well, be gentle in general. We don't want to cause a patient in distress. But when you hit the inner 2/3 of the ear canal, that's when you raise the stakes. The last thing we want to do is, or I want to do anyway, is cause the patient any harm or discomfort. So when the inner tooth hairs are on high alert, and we're just going to be so gentle because you've almost got exposed bone. So that epidermis layer is about 0.1 millimeters in thickness. So it's 1/10 of the thickness compared to the skin that lines the cartilaginous portion. Now, these hairs, do they cause a problem? Not really. On the right side, there was a few more, and the ear was a bit narrower, so it did obscure the view a bit more. But will we remove this? No, because the only times I've had to remove hairs when it's so much and it's just impossible to see beyond the hairs, and I'll just pluck them out using forceps. Otherwise, just leave the hairs there. You pull them out. Going to cause probably a bit of discomfort for the patient. Generally, it's tolerable, but it's always a risk of developing folliculitis, which is an infection of the hair follicle itself, which we don't want. That can lead to a furuncle, so almost like a spot, a pimple. Could be pus-filled or blood-filled. These hairs actually serve a purpose. The sebaceous glands are attached to the hair follicle itself, so when they secrete sebum, sebum is transported up the hair root through all the layers of the skin and then to the tip of the hair, and then it lines the canal wall, and it dissipates and lines the inner two thirds of the ear canal and also the eardrums. Although the sebum is secreted on the outer third, these oils do evenly spread all the way across the ear canal wall to moisturize the skin. And the ceruminous glands, although they're not attached directly to the hair follicle, they are located in the dermis layer, and they have pores that extend to the surface of the dermis. So that's where the secretions are transported upwards. That's the patient's eardrum, nice and healthy. So yeah, these with the absence of the hairs, you're not going to have any sebum. Sebum's important. So we also find this on our scalp, and it helps to nourish the scalp. So it provides a thin film of oil to help the skin underneath retain its natural moisture in the absence of sebum, and also the oily sweat secreted by the ceruminous glands. There's no protective film sitting on the surface of the epidermis, and therefore any moisture in the dermis layer of skin, it rises to the surface and it evaporates, so it causes very dry flakiness of the skin. So this sebum and oily sweat, it's there for a reason. It's there to moisturize the skin, help the skin retain its natural moisture. It's also acidic, so the acidity helps to, believe it or not, it repels insects. It's a natural insect repellent, and it's designed to help inhibit bacterial and fungi growth. Having the ear being slightly acidic is very important. Most patients who develop otitis externa, an outer ear infection, if you measure their pH level of the ear, it's increased and it's more alkaline or more neutral. So we want these natural oils. So you can see that the hairs are a bit, well, almost call them whiskers. They are quite thick, and they're extending from the posterior canal wall of the first bend. So, but once you get past that, you can see, you'll get a better view. When I start removing the more medial wax, these hairs won't be visible. The reason why they're visible at the moment is because the wax is near the entrance, and of course the endoscope is positioned in such a way we can view the hairs. Sometimes it gets a bit frustrating because I can't change the patient's ear anatomy, and we had an email sent from a viewer to my work email address, and I must stress, guys, please don't send emails of these natures or these negative comments as we've had a few in the last couple of weeks, to my work email, because it is a working clinic, and my clinic manager and deputy clinic manager, they're really, really busy booking in and arranging appointments for our clients, and I mean, they're a bit flabbergasted sometimes by some of the emails that we receive. And so if you don't like the videos, that's fine. I'm not going to try and convince you otherwise, but if you want to leave some comment in the comments, feel free, but please don't email my work address. That's completely separate to these videos. And it's not fair on, as I said, my clinic manager and deputy managers. They're so busy in clinic, booking patients and making our patients feel welcomed and hosting them, because it is a front of house. And it just gets a bit frustrating for them as well, having to read all these emails, and they ask me what do I respond. I said, just don't respond, just leave it. We've got better things to do. So, and the reason why I mention that, because it's videos like these where I've got hairs there. Oh, why don't you pluck them? Why don't you cut them? And it's fine if someone asks, but when we get hateful emails, it's not nice. We're here to help people, and we shouldn't be exposed to that, really. And I can't change this patient's ear anatomy. What do you want me to do? I can't burn these hairs. I can't tell the patient not to have these hairs. It's their anatomy, and the risks of cutting them and pulling them are far more than the risk of just leaving them. They're not causing me a problem. I can remove the wax. That's like this patient. They've not come for a haircut or a manicure. They've come to have their earwax removed, which is what I'm doing. But yeah, I appreciate it's sometimes the views. It's slightly hampered, but it's not enough for me as a clinician to worry about. And first and foremost, these videos are, we're treating patients. They are at the forefront of my mind. So now this is the last plug. It is a bit matted, just pulling it through just near the entrance here, and it's just got trapped. So if memory serves me, I'm going to use a hook, I think, just chisel it. So just going to go over the top. Now, I've got my new range of instruments going into production, hopefully this week. So the wax scope, it's more or less ready now, guys. It's been a long delay, beyond our control. But I'm going to hold tight until my instruments are ready. I want to launch everything at the same time. We're also developing a new app, which has got this new Zoom feature. I have demoed it on my other YouTube channel. So if you look in the description, I've got the Clear Wax YouTube channel where I showcase the wax scope, and in the more recent videos, which I haven't uploaded for a while, but I will be uploading some more wax scope videos on that channel. You can see we've got a new Zoom feature, and I'm just going to launch everything at once. It just makes more sense. And some of these instruments that I'm developing, they are designed not just specifically for the wax scope. It doesn't matter if you don't use. You can removing wax using any visualization technique, and they're suitable for all modes. But they do work very well with the wax scope. So I'm just going to wait now. We've come so far, but everything's looking good. And the instruments, hopefully, they're going to be a bit more helpful to the current. I mean, the instruments that I use are really good, but I think there's room for improvement, and I think I found that. So that's all the dead skin keratin plugs. Some bits are darker than others. They're the oxidized bits. So they're the darker sections. It's just been there longer. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.